Okay, so hey everyone, I'm David Klabonis, and I'm with Palm Beach ACO. We are a network of physicians down in South Florida, it's in Palm Beach, Dade, and Broward County. We have about 240 primary care doctors and about 160 specialist physicians. We're really excited about the ACO project. We feel like that we have a national responsibility to show others that PCP-driven care is superior. And, you know, one of the things that we like to share with others is that, you know, if we don't succeed as independent PCPs and the hospitals succeed, you know, it's all well known that when a hospital buys a primary care office, they bill 25 to 30% more for the exact same services. And that's a challenge to us because, you know, that hurts the employers who they're challenged because their premiums go up each year. And that hurts the patients that, you know, it's not a very good thing for the patient when their premiums go up, you know, 25%. And their co-insurance goes up 25%. So we're a network that constantly is building the message that independent physicians can succeed and the ACOs can succeed. And I'm really excited to talk about this conversation, which kind of flows into the bundled payment model, which is another model that's out there, and we completely endorse it. However, we want to help other ACOs also succeed with the bundles. There's kind of some things that aren't well known, and we want to kind of talk about some things that we learned, and then set ACOs up to have the best possible combined success with bundles, hence win-win. All right. Hold on just one. Getting a bunch of messages. Okay, so this next slide, it's not to boast, but it's to say that physicians can do it. So this is a very difficult project. There are some ACOs that haven't made money in year one, and we just want to say that there can be light at the end of the tunnel. We have entrepreneurial physicians. We put in an incredible amount of hours. We actually were having trouble making payroll before our check came in. And then, as you can see here, we came in one morning and we had an extra $22 million. So, you know, if you're able to work hard, have the right tactics, you know, success is there. And we're trying to spread the message that as many organizations can have success as possible. Now, I wanted to give a brief acknowledgement to where about half the content is coming from. Robert Mechanic, who I actually spoke with on a panel, represents a lot of the bundle payment base. I'm going to go over just some bundle payment background for those of you that aren't familiar with the bundles, with the BIPC program, and then I'll jump right into what Palm Beach ACO is doing. But Robert Mechanic, he's the developer of all the content. So the bundle payment for care initiative, what that offers is a lump sum payment for roughly 30 to 90 days of acute or post-acute expense. And what Medicare has done is put entities at so that not only are they providing the DRG or the SNF, but they're actually accountable for all the expense that precedes. We all familiar that home health, SNF, readmissions can be very costly. So Medicare is now assigning, you know, this 90 days of expense to the bundled payment initiator. And then this is model 2, which, as you see, will include the hospitalization. These are typically initiated by hospitals and hospitalists. And then here is the model 3 model, where a bundle is still initiated at the hospitalization, but the bundle payment is actually just the downstream expense, nursing home, readmission, home health. To give you guys an idea, in our area, average model 2 is about $30,000, and the average model 3 is about $20,000. Now, there's one item to present here, is that Medicare takes all the calculations for the previous history of the bundle initiator, and they calculate a target price. And Medicare's smart. They take a little bit off so the target price is basically what used to be spent on the 90 days post-acute of a particular episode, a particular DRG, without the 3% that Medicare takes off the top. So it's a good deal for Medicare, presumably, because they get the 3% savings. Now, not all the profit to the bundle initiator with the risk taker, and Medicare has created a way that you can participate in gain sharing for doing a great job to help these initiators take risk. We're excited about this. Our physicians are participating in gain sharing. The primary care physician in our specialist network, we can do a lot to reduce readmissions. We can do a lot to manage SNF length of stay and eliminate inappropriate home health. And it's great that Medicare allows the episode initiators to pay us for it through gain sharing. The types of episodes that are out there, here are the DRGs that are gaining the highest popularity. If you look at this, there is some rhyme and reason here. Total joint replacement is a big opportunity to manage post-acute expense. There are many doctors that pay very close attention to the SNF and home health that's used post-total joint. Plus, there's a lot of work you do pre-total joint to reduce readmissions, pre-clearance, et cetera. Some of these ones right here we identify as well as being big opportunities for readmissions. So you can kind of tell the logic of the bundle awardees, the bundle initiators. They're looking at the lowest hanging fruit first. Good for them. This is kind of what's going out there as far as the percentages. This is an interesting slide showing the penetration of the market. This is a little bit old, but we can all see that the percentages are relatively low by state. I would say that this is more than doubled since this slide. And if I get access to updated information, I'm happy to share that with the team. But, the BPCI is growing, and you can see by state, here's Florida down here at the bottom. It's one of the larger states. Obviously, it's out of the top 10, but it's still a relatively small penetration. I want to add something here is that our perception is that Medicare is trying to fix the growth in healthcare expenditure and the quality challenges that are out there. They're paying top dollar, and there's no perception that there's an improvement of quality or patient satisfaction. So this program is another way for them to improve in addition to ACOs. So, what I would suggest to the team is that the bundle isn't necessarily competition. It's just a way to onboard more of the providers onto population health. And as you can see, the percentages are low here. I still think that ACOs are only like 20 to 25% of the Medicare fee-for-service population. So if we're 25% and bundles are 10, 15%, there's still 60% or more that doesn't have a value-based program. What I would add is that like maybe in South Florida, we're interacting with the BPCIs, but there's still a lot of the country that there's no interaction, where there's one or the other. And that's where we applaud the BPCI, is that you might as well have some type of program to more onboard the nation onto value, right? And then that's the point of today's conversation is if you happen to be in an area where there's BPCIs, how can we best work together? Laura, am I doing okay? Can you hear me?
Yep, I can hear you perfectly. Everything's going well.
All right, great. So, we were sort of surprised to see, how much of an impact the BPCI would make with our interaction. One day we woke up and there were a lot of hospital CEOs reaching out to us saying that we should give up our shared savings because the bundle was the new business model. And we're a network of physicians and we're okay at politics, but hospital CEOs, that's really their strength. They're really great at politics. So we were sort of surprised by everything being dropped on us. And what I want to share with everybody is it's really small here, but if you look up CMS BPCI Model 2, the analytic file is really our bread and butter. What that shows is all of the BIPSI participants in your area, and it is public record. And we were surprised that, as soon as we started hearing about the BIPSI, that there were already 87 participants in our area. Now, don't get me wrong, that's 3 counties, but boy, that's a lot of IUD-based programs that we should be aware of. And when we started sharing the information with the docs, it started making sense, because they had heard some changes in the community of how care was delivered, and now this started making sense. Oh yes, the hospital is now being paid differently. No wonder they have care navigators, and they're asking me to coordinate with them. So it really kind of started to illuminate why some things were occurring. But if there's anything you guys take away, please make sure you're aware of the BIPSI awardees in your area, because it definitely could affect your payment, and it definitely could affect how healthcare is delivered in your area. This is a difficult slide to see, but we're trying to learn from bundles, and what's amazing is that it really illuminated for us the opportunity in post-acute care. So if we look at total joints on here, there was a couple things. I'll just talk about 2 of these DRGs, but it says that 12 points of total joints go to inpatient rehab. And those of you that study inpatient rehab, you may know that it's 2.5 times as expensive as SNF. And we took this data and we shared it with local orthopedic surgeons, and they were surprised, and they said, wow, this is a great opportunity for us to use skilled nursing facilities instead of inpatient rehab, especially knowing that it's 2.5 times as expensive. Furthermore, it's interesting to note that on a total joint replacement, only about 11% of patients are readmitted. And if we go down to, for example, COPD or heart failure, you're approaching around 40% of the patients are readmitted. It really kind of opened our eyes to DRG-related care. We had used the population health models in the past, and this is really kind of something that's added our depth. When you talk to a doctor about how their specific COPD patients are 50% being readmitted when the national averages are 40%, that really opens eyes. It's a lot better of a conversation than, hey doc, let's reduce readmission. So I guess our point is that we're really learning from the bundle as well. It's opened our eyes to post-acute, and then obviously there's a lot of patients that aren't in a BIPSI where we get full benefit of the savings. If they aren't a BIPSI, they get most of the benefit of the savings. But it really kind of opened our eyes to some opportunities. One additional thing I wanted to point out was that 39% of patients go to the SNF post-total joint replacement, right? So it's interesting that 60% of patients go home, presumably with home health, post-total joint replacement, knees and hips generally, right? And then when we started kind of digging into this more with our specialists, absolutely, a lot of total knees can go right home. And if the patient's young and they have a really good caregiver situation, even some total hips can go home. But this report right here in particularly really added to our depth, and this is available as public record right on the BIPSI webpage. It's kind of like their handbook. So here's the conversation that most people talk about with the BIPSI, is that it's nice that the awardees are able to take some risk on behalf of the ACO. And it's nice that they can, if the patient is sick and there's abnormal readmissions, then they hold that burden, and the ACO is guaranteed 2 to 3% of savings. We were able to save 7%, and we're so proud of that. This is less than we're typically saving. A lot of our savings was post-acute. So at the surface, this seems like it's good for some and not so good for others. It's just something to be aware of. If the BIPSI can and work on post-acute expense on their DRGs, and we can reduce admissions, boy, it might be a nice combination. But it's just something everyone should be aware of. Some of you, your ACOs, if you're less than 50,000 lives, I believe, then your MSR is greater than 2. So, I'm talking about your minimum savings right here. It's the minimum threshold we all have to hit to get paid. And, maybe if there's a lot of BIPCs in your area, it could be diluting, right? These are some of the complaints. We don't 100% support these. We feel like that, it's nice to have other people join the value-based programs and kind of attack this nationally with us. However, these are sort of the complaints that a lot of people had with the BIPC is, wow, these BIPCs are really going to hurt us. So I wanted to kind of share, this is sort of the critical part of my presentation is this the whole story, right? Is this kind of the things that we should be focused on with the BIPC interactions? So our approach with the BIPC is that we like the program, and candidly, we wish we had jumped in. There's some orthos in our network, there's some hospitalists in our network, and it would have been a nice way for us to pay them more money to use our network to take risk. So, as soon as it reopens, it might be closed now another, 18 months or so, and if Medicare CMMI continues the program, we're definitely interested. However, right now it's closed, so what we are doing is we are participating with existing BIPCs. Let's just say there's a hospital. Most hospitals are not great at managing post-acute care. In fact, they're the opposite. They're great at promoting post-acute care because typically post-acute care, increase in SNF, increase in home health, that reduces length of stay, which helps the hospital. And it also, hypothesis is it reduces readmissions. So our network has some skills to reduce, post-acute expense, and we're trying to leverage that. So we have, several gain sharing agreements with local hospitals. There's some laws around that, so we're trying to make sure that we're able to benefit our docs as best as possible. But, we were able to take our network, our proven track record, and communicate to some BIPC awardees that, number one, they don't have to do it all by themselves. They're probably getting a little bit nervous about that. But number two is that, we're a superior network that, we can really reduce the readmissions and really help them manage this cost. So we do have some programs in place to help the awardees and promote, their ability to take risk and deliver a profit to their organizations as well. And a couple innovative things that we did is, we are the PCPs. So when you do post-acute care with us, you don't have to ask in order to get an appointment with the doctor, 2 days or 3 days post-discharge. The two valuable things for us is that if the patient's seen immediately post-discharge, they can do a med reconciliation. We can eliminate polypharmacy issues. They can immediately manage the home health. Many of you know that if you cancel a home health order within the first week or so, it can be canceled completely. While if home health continues for a couple weeks, they actually get paid roughly for 60 days of service. So if you don't address home health early, then it's paid a lump sum. So, the same day office guarantee, it really kind of enables us to get a hold of that patient and make sure we can help these BIPC awardees. The other thing that we did is that, scheduling the appointments. So, it's nice that a lot of our offices offer the same day guarantee, but, our team, we have an in-house call center, actually schedules the appointments if they're in the ACO or not. And, the hospital employees, they're not so great at that. So, we were able to kind of leverage our services to help out an awardee, and it ends up being a win-win. I tell you, one of the big benefits we had is that, we're now integrated in the hospital, and we're learning all kinds of workflows. We're learning about case managers. We're learning about hospitalists. We're learning about, how care is delivered with specialists. Some hospitalists have, more or less specialists that see any given patient. But this has really kind of illuminated our understanding of workflow in the acute, in the OBS setting. So I would definitely recommend this. If you can integrate with a hospital or, another type of awardee, this has really been a home run for us. So I'll jump in real quick. I just want to make sure I give an appropriate disclaimer here is, the project is early, and it's not like there's 4 years of data and, it's meeting N and standard deviation metrics. This is operational data that we're finding, and I want to make sure that I'm able to share that with you guys with a grain of salt. It's a brand new program, and we're all just kind of learning. So a couple things that we kind of mandate is, BIPSI or not, we want to make sure that payment doesn't change workflow. So, if there's a lot more admissions into the hospital, Medicare shares with us that 80% of the patients that go to the ED go home, and 40% of patients are admitted. That's one of the top metrics that we track. And as you'll see from our slides, it can be dramatically different. There is a 60 Minutes video that talks about how there is a hospital network that at least one time they influenced physicians to admit a higher greater percentage of patients. Now, we're not saying that that's happening or that the BIPSI promotes that. We're just saying that it's something that we were tracking before the BIPSI ever occurred. But the bottom line is that if somehow a lot more admissions occur, the hospital benefits from the DRG, the BIPSI benefits from initiating these target payments, presumably from less sick patients. So if your patient's less sick than the patient that was admitted the previous year, that translates the profit to the BIPSI. So we just want to make sure that payment does not change the workflow, and that physicians are making decisions as to what patients need to be admitted, and that care is coordinated with the physician as much as possible. Another thing that we want to make sure that we're trying to avoid is that if the BIPSI suggests that the PCP is no longer allowed to see the patient, that's unusual to us. We would try to make sure we earned that. Hey, we're the PCP. We're very hands-on. I know there are PCPs in the community that may not be hands-on post-acutely, but we certainly are, and we really want to see the patient immediately post-discharge. And we want to make sure there's no walls put up by a payment model. We just think that's strange to patient care. And then the final thing that we're really trying to make sure we focus on, again, we've always tracked 100-day readmissions, 180-day readmissions. Medicare tracks 30-day readmissions, but we think 180 days is probably a better indication of how well we put to transition the patient from acute to post-acute back to standard preventative health. And we want to make sure that if we do work with a BIPSI, that all of the care is not delivered at 90 days and then just cold turkey, right? Because that would have a huge detriment to ACOs who, as you guys know, we're on the hook all year for these patients. And, you certainly could have a hypothesis that if there's professional care navigation for 90 days, it all of a sudden stops. Are you guaranteeing readmission, right? Boy, that caregiver feels really uncomfortable now that nurse case manager who was calling weekly all of a sudden stopped. It might be time to go back to the ED. So these are kind of things that we've been always tracking, but the BIPSI has caused us to pay a little bit more attention to make sure that the payment model does not influence patient care. And here's a quick just a picture of that is, when it comes to the BIPSI, we want to make sure we focus at the episode initiation, that there's an appropriate amount of admissions. That's a core value, a core protocol for all ACOs. Hey, are you making sure that the patients that are being admitted, are they appropriate? And then, if we do have a BIPSI partner, after 90 days, how are they transitioning care back to the primary care doctor so we can do normal preventative care, normal chronic disease management? We want to make sure that this little block right here is not the only time that great care is delivered. So this is kind of how we're working together with BIPSIs. And honestly, if you fall apart at either one of these places, you're going to be really, really upset by your financial results. So here's a bit of there we go. This is a little bit of a hypothesis, and we have some data I'll show you on the other page that we have some concerns with. And the concern is that, there's certain patients that present to the ED where there is some disposition. Maybe they do an additional phone call to the PCP. Maybe they do a little bit deeper dive to call the cardiologist or request the most recent stress test. But there are tests and knowledge that a primary care doctor with 5 to 10 years of experience with a patient may have that the emergency room doctor does not. And the concern is that if before the BIPSI, 61% of the patients went home and 39% were admitted, this is real data for us, that, after the BIPSI, when the awardee gets additional payment for admission, we wonder that these tables are going to turn, right? So these are things that we watch always, but we want to make sure that we're additionally watching the BIPSI. If it goes 50-50 here, as you can see, 61% went home, this would be a huge detriment to all ACE trust fund, because the expense difference between an ED admission and an ED discharge is substantial. It's about $7,000. So, we want to make sure that we're not focused on 2 or 3% in savings and losing $7,000 just in case the BIPSI awardees focus a lot more on post-acute care and not making great decisions at admission from the ED. Now, this is kind of an alarming, these are stats that we found here locally. It wasn't an enormous sample size, but this is a Model 3 BIPSI, and you saw from the data that total joint replacements in our area, about 61% went home and about 39% went to skilled nursing. In our area, there's a couple Model 3 SNFs, and if the patient goes to the SNF, it initiates the episode. If the patient goes home, then it doesn't initiate the episode. So, of course, they're at risk for the bundle, but obviously they'll get paid more if a lot more patients go to the SNF. Presumably the reason why is because these patients that went home are a lot less sick than these patients went to the nursing home. So if these patients that used to go home are now going to the nursing home, they're getting a flat rate on much less sick patients. And our data supports that our numbers in this area are much like this. Now, this has since kind of stabilized because of the education we provided, but we want to make sure we're sharing some of the things that we saw. But there's definitely, when the nursing home initiates the bundle, there seems to be a lot more patients going to skilled nursing, and we take responsibility for that, and our primaries are now vigilant to make sure they're involved in the care and that patients are going to the nursing home post total joint replacement as necessary and not influenced by any type of payment model. So this is real data also. It's from about 6 months of this year and from 2014. The big thing that, again, we certainly don't think there's any devious plan here to automatically admit patients, but we really kind of are asking the question is, where is the work being done? And, if a BIPSI is paid 100% based on the post-acute expense, does the care navigator get initiated and does the process get initiated at ED of chest pain and even before the admission occurs? And if that's the case, is it possible that some people are taking the eye off the ball of doing an appropriate admission and they're immediately focusing on hurrying admitting and doing and managing the post-acute expense? So this is real data for us, and we find it pretty remarkable. As soon as we ran this data, we've actually gotten to work on these hospitals, but it's pretty remarkable. So in 2014, so this is 2014 before, and we got a large sample size, so this is statistically significant data, right? Is out of 1,804 admissions at this hospital, Hospital X, about 32% were admitted and 67% were discharged. This is very good performance at this hospital, by the way. And in 2015, we noticed that amount went up dramatically. right? And we've started to ask questions as to, hey, ED doctors, can you continue to coordinate care with the PCPs? You may not have known, but we're very interested in getting you the most recent medical records. We're very interested in answering your calls when you call us, so that you can get a shared decision with the primary care doctor, and you can make the best and most detailed assessment if that patient needs to be inpatient. So this was sort of alarming to us, is that why is it going in the wrong direction? And then I wanted to bring this next hospital to your attention, is that this hospital is 50% less good than this hospital. And they're both in roughly the same mark. And there's not a trauma center here. There's not a heavy cardiac unit. These are pretty small community hospitals in sort of suburban West Palm Beach area. And it was pretty remarkable that this hospital admits 55% of the patients that come to the ED, and they discharge 44%. And this was in 2014. So it seems like their ED care coordination, the PCP, is not nearly as good as Hospital A. And then it's going in the wrong direction. So, we shared this data with that hospital immediately, and with those emergency room doctors, and we're getting to work, because we want to make sure that they understand that there's an opportunity to maybe do a more appropriate discharges and be a little bit more even with the rest of the market in this area. But what's remarkable is there's a direct correlation with those ER doctors and those ED teams that coordinate care with the PCP. I could have told you this one was going to be very low, because the ED doctors have detailed processes, they have relationships with the PCPs, and they're very adamant that they're interested in doing what's best for the patient, and that includes appropriate discharges. This office, they're not bad. This hospital, they're not bad people. They're just busy, right? And that's sort of the challenge. We want to make sure that hospitals that are busy, hospitalists that are busy, that they're not necessarily rewarded for that they're rewarded for doing a deeper assessment and doing more that's appropriate for the patient, like up here. Now that sort of wraps up sort of where we are from our BIPSI analysis. We wanted to share some of this key data. Is if you're looking at the 2-3% savings from from the bundle, you might not have the whole picture. And then, we wanted to share some of the really positive things that we've done with bundles. We think that, they're certainly here to stay, and that if we act early to work with them, then we're going to get much better results for the patients, as you guys can see here. And, Laura, if you'll allow me, I can certainly open up some questions. I just want to make sure that, all ACOs, they have this on their radar, and that we have a plan that, our payment model, which is the MSSP, and maybe next gen, that we can make sure it's long-term and continue to do high-quality, high patient satisfaction care.
Yeah, sure. Anybody, if you have questions, you can either type them in the chat box, and I'm also going to enable Q&A mode so that you can ask questions over the phone as well. Bear with me just one moment. Okay, so Q&A should now be enabled if anybody is wanting to ask a question. If you need to ask a question, there should be a little hand icon that you see that you can go ahead and say, ask a question. If everybody on your screen, if you kind of look at the bottom right, there is a little hand where you can say raise hand. Okay, and David, it looks like we've got a question from Alan Gilbert about if the copy of the slides will be available when the webinar is complete.
Yes, absolutely. I'm just I want to make sure I give the appropriate reference to to Brandeis University, and as soon as I can get that finalized, I'll make those available.
Okay, wonderful. And we can go on ahead and coordinate getting those sent out to all of the attendees once that's available. And looks like we've got a question from Stephanie. How are you incentivizing providers internally to coordinate care? Are you setting aside incentive pools of dollars, et cetera?
So we're year 3, and it's kind of hard to imagine back before we had shared savings payments. But we really tried to capitalize on the existing Medicare CPT codes that pay doctors to coordinate care. So, we have really heavy transitional care programs where we show how to bill for the TCM, and we think that's one of the best ways to reduce readmissions. Additionally, there's a payment, I believe it's G0180, that pays the doctor for appropriately approving home health care. So, many PCPs weren't aware of these charges that Medicare was encouraging, and it actually had overall cost savings and increased coordination of care. So what we did is we showed them what Medicare had already provided them. We helped them make sure they can bill and collect. Sometimes they have collections problems, and we can share what our network is doing to make sure they get paid. And that's been kind of the number one way that we've driven physician engagement is through more CPT and better billing and collections through Medicare.
Okay, looks like we have another question. Does the ACO have any contractual relationships with the hospitals in your area?
We're pursuing several things. We're working together with the hospital. I'm not going to call it a contract, but we're in operations and they're involved in ours. We're kind of trying to come together on a deal with one, and we have a few other discussions with others. But the key thing is that we're a really strong primary care network, but we can really benefit by coordinating with hospitals as well. And what we talk to hospitals, our line is that if we can work together, we can really reduce length of stay, we can really reduce readmissions, and we can both benefit from both volume and value. Because there are some hospitals that haven't taken the plunge from a value perspective. They don't know that they can make money through these programs. So we really try to, plant the seed that we're a network of providers, and if you do a great job, we can send you more volume because that's what's better for the patient. And then we can be great partners for you if you want to take on these value-based payments, and we can make sure that you can ensure success.
Okay, we also have another question. Are the hospital costs transparent, and do you have the data available to you? Do you get ADT data from your hospitals, and does that data diagnose information? Or does that data diagnosis information?
What a great question. Are hospital costs transparent? No, right? So we don't know if OBS is always better than an admission for sepsis. Some of that stuff is really confusing. The 2-day rule now has recent, 2-midnight rule has had recent changes. And we don't know the ins and outs on that. But what we do track is we track the percentage of admissions that come from the ED. We, as you can see on my slide up here in the top, we track average admission expense, average ED expense. So if there were any changes, it would come on the radar, and then we could at least have that dialogue with the hospitals. And then we do get ADT data. I'm going to also endorse the Florida HIE. So we enrolled in that as soon as it opened up. It's difficult to phase in ADT data from each one of your hospitals. It's an interface, and those of you that do interfaces, it takes a very long time, and it needs troubleshooting, and it can go down. But the Florida HIE has connectivity with every hospital in the state, and we're getting real-time notifications. And we're early in the process, but we're very excited, and we're getting results. We have an anecdote that one physician just got turned on, and he prevented 2 hospital admissions last month. So that's, if you look up here, if the hospital admission is $7,400, then our tool set with that doctor alone just saved almost $15,000.
Looks like we've also got a comment from Leonard Hawk. It says, David, this slide, and I'm assuming it's referring to the one that we're currently on, demonstrates that we can move the hospitals and they no longer move all of care delivery.
Yes, one strategic thing that we have really been illuminated on is, PCPs aren't that involved in hospitals. Our PCPs, they don't typically lead service lines. They don't lead the ortho division or the cardiac division, and associate PCPs with revenue, and they associate the specialists with revenue. So you can imagine who the hospitals are working with first, and they're working with the specialists. And our specialists, many of them are in the ACO, and they have an active role. But as soon as we started seeing the BPCI, we saw as an opportunity to more engage the specialists. So, we have that same conversation is that, we promote what's right for the patient, and we have pockets just like the hospital to pay you for doing a better job. And we also represent quite a few referrals in your area. So, if you do a great job and the data shows that, then we think you're going to benefit. So we've really kind of engaged the specialists, especially the service line leaders at the hospitals, because they're the ones that are really being influenced the most by these programs. And we make sure that they're committed to our PCPs as well as the hospital, and maybe not just committed to the hospital.
Okay, we've got another couple of questions here. Has your ACO started developing chronic care management capability to assist PCPs with this service?
Not the ACO at this time. We have several vendors that we introduce the doctors to if they express an interest with chronic care management. Also, they kind of have to earn that they're trying to do it for the right reasons. One of the concerns with chronic care management is, hey doc, why do you want to do it? And they say, well, it's because I can make a lot of money, and then it just throws up red flags. But if they really truly believe that the 20 minutes of nurse case management is going to reduce readmissions and improve patient satisfaction and improve the quality of care, then we definitely endorse it. And right now we're vendor oriented. Who knows? In the next 6 months or so, we're growing. We might be able to transition that in-house, at least for some of our offices that we're already integrated in. But right now, we recommend a couple key vendors that have passed our initial conversations, and some of our offices have already signed up.
Okay. Another question. Do you collect any clinical data from the EMRs across your network to identify care gaps and other preventative items that PCPs can take care of to help better manage your diabetic, COPD, and others?
There's a really key word in here called EMRs, right? So our integration is we chose to skip the EMRs. So we have a very large network. We have 150 offices, right? Some of those have 3, 4, 10 doctors. And, I have a little bit of experience with integration, and that would be difficult to have HL7 CCD interfaces with each one of the 150. So we chose to take a different route, and, you can get some of this data directly from the vendor. So there are 2 lab vendors in our state that have huge market share, and we've already connected with them. So, it says diabetes on here. So we are able to collect gaps in care for diabetes measures, particularly hemoglobin A1C and LDL. And then we're able to, we're in the process of connecting to Florida shots, in which we'd be able to, it says here preventative items, we'd be able to track through the state registry, who has their pneumonia, who has their flu shot. And then obviously we're very pleased with our connectivity with the HIE to get the real-time data. But, our recommendation is that there are some ACOs that they say, hey, stop. Step one needs to be that we need to integrate all these 150 offices and inherit all the challenges with that. And we found that, you can do a lot with, with the data from the HIE and from, the lab vendors in the area. And then, if you can engage your docs to do TCM and manage the home health, found that to be a little bit more short-term gain than, perhaps advanced diabetes, chronic disease management programs.
Okay. Another question. Have you eliminated SNFs or outpatient rehabs from your network due to high costs or long length of stay?
What an awesome question. So we don't eliminate anyone from our network. We share data, and our doctors make their own decisions, and our patients make their own decisions. You guys probably are aware that, one of our key quality metrics is patient satisfaction, and one of the 7 items is shared decision making. So we want to make sure that our doctors have the tools to share the facts with the patient to make a shared decision. And we never eliminate any provider. And if there's a provider, it says a SNF or outpatient rehab. If there's a provider and their data's having challenges in the short term, and they work with the local PCPs and they're able to earn their respect, and they improve their data and they improve the service, then we'll absolutely communicate that to our network. So we want to use the best possible providers, and no one's out permanently. And I wanted to share too is that, it's easy to get to cost data from the Medicare claims data. And you can see that cost data here on this slide. However, we've really tried to increase our depth. So, there's national databases that include Home Health Compare and Skilled Nursing Compare, and the reports that we now put in front of primary care physicians to help them make the best shared decisions are now including patient satisfaction scores, and whether or not there's a high chance of being readmitted from that particular home health agency, as well as if they're doing subjective type programs like do they do medication education or fall risk assessment. So we're really trying to increase our depth to help better decisions without eliminating anyone from the network.
Okay, looks like we have one last question. Do you think that in the future you will be able to accept full risk without EMR integration?
Yes. So, I mean, we've really worked hard, and I stand on the shoulders of entrepreneurial physicians that have really extraordinarily changed expense in our area, and we don't think that EMR integration is a prerequisite. So, obviously we would look out for, Medicare to help us with a little bit more controls and a little bit more visibility on our patients that we are taking risk on. One thing that we were sort of disappointed with is that they didn't do the 3-day SNF rule for the Model 2, the Track 2. And, we think that as Medicare phases in to have more controls and more data, then we'll be poised to take risk. But right now, the EMR integration, it's not the top of our list. Again, I described that, we're able to get really meaningful, actionable data to get most of the job done without having the complete integration, but rather partial and perhaps meaningful.
Okay, I think that wraps up all of the questions. So, David, thank you so much for your time today and for presenting, and thank you everyone for taking the time to be a part of this webinar. Again, as soon as David makes a few tweaks to the presentation, we will get that sent out to everybody. You could access the recording as well. If you have any questions, please feel free to email either myself or David. And again, thank you so much and have a great day.
Thank you.